Welcome everybody, and thank you for joining us at the National Pharmacy Association's Winter Conference for 2020. It doesn't seem 5 minutes since we were signing off on the summit. So here we are, we've got the NPA delivering for you as usual. Firstly, before we introduce who's going to be speaking today, just some thank yous really to our sponsors. We've had Medic Spot, we've had Pharma Wealth, and Instant Dentist, who sponsored this session today and the conference. So we're really pleased and just want to thank them for doing that. So the title of the conference is Enabling Community Pharmacy to do so much more. And joining me today are Gareth Jones, Rena Barai, Michael Lennox, and Nick Kay. And it's going to be a bit of a panel sort of session, and each of us are going to, present our little slots, and then we'll give you, the audience, the opportunity to ask questions of each of the speakers. So without much further ado, community pharmacy has really demonstrated more than ever this year its value to the NHS and the public. And with the challenge of the COVID-19 still here, how can community pharmacy be put on a more sustainable path to the future? Clearly, that's something the NPA has been set that challenge by the membership. And, we've got effectively a lot of practical sessions on maybe what to do here and now during the conference. This opening session is actually going to cover the longer term. How can we ensure that the sector is sustainable and, in fact, thrives in the long term? And the NPA also has a key role in facilitating a debate amongst the independent sector. So without much further ado, I'm going to introduce Gareth Jones, and he's going to effectively set the scene. So Gareth, across to you.
Thanks, Andrew. Okay, if I can have the first slide, please. Thank you very much. Okay. Well, I'm just going to spend a few minutes really talking about where we are now and providing some evidence on where we are. And the first piece of evidence I want to highlight is some public polling that was undertaken, commissioned by the NPA in the middle of summer in June, to look at what the public perception of community pharmacy is at the moment. So this involved over 1,000 adults being polled by a polling company. So we found, importantly, that the net favourability for community pharmacy is 77%. That is an incredibly high score. It's the polling company that did this work, so they rarely come across favourability ratings so high. Community pharmacy is very highly rated by the public. And the public also already in June recognised the incredibly important role community pharmacy played in the pandemic. So 89% of those polled regarded pharmacies as essential during the pandemic. So they also looked in more detail at how pharmacy generally and independent pharmacies specifically are perceived, and the public very strongly felt independent community pharmacy was friendly, helpful, trustworthy, and that the primary focus of independent community pharmacy was people's health. Interestingly, when we've had years of debate about whether there are too many pharmacies, driven by some within NHS England, only 4% of the public actually felt that there are too many pharmacies. The vast majority felt that there are the right number, or actually some felt there should be more. A really interesting piece of information we picked up from this piece of work was that 29%, only 29% actually, are definitely aware that pharmacies are part of the NHS. Now, of course, we know that strong link, and we know how the link between community pharmacy and the NHS is effectively the same as the link between general practice and the NHS. But that perception is still there, and I think when we think about where we're going in the future, it's important to think about, we have a very strong brand. The NHS has a very strong brand. What can we do to get everyone to see the two linked together very closely. And we also learnt that when the public were given two visions of the future, really, one which focused very much on the local pharmacy and its face-to-face role and in health and well-being generally, and the other being mass automation and centralisation, and possibly even losing access to pharmacists in the community pharmacy. Only 11% supported that alternative vision of the future. The vast majority want to preserve that easy access to a community pharmacy in their neighbourhood. I'll move on to the next slide, please. And that's some more recent data, polling data, again commissioned by the NPA, which we did in anticipation of Asking Pharmacists Week, which started last Monday and comes to an end today. And that asked some slightly different questions. It asked about how many people had been to a pharmacy during the pandemic. 68% of the public reported having been to a pharmacy at least once during the pandemic. Now, we don't have figures to benchmark against other providers, general practice and hospitals, but clearly community pharmacy has seen an awful lot more people than any other part of the service, which happens anyway, but particularly during the pandemic. And 35% had visited a pharmacy due to their GP being unable to see them. And once general practice will become more accessible over time, general practice has fundamentally changed. The way that they are going to work has changed. They're going to be more digital. And I think this fact that people see pharmacies somewhere they can go in their local community for face-to-face care could become even more important than it has in the past because of the way GPs are going to work now. So of those people that have been to a pharmacy because they couldn't get into their GP, 42% for a minor illness, 33% for access to medicines, 15% for health checks, 12% for changes in their body. They would have normally gone to the GP as the first port of call. We also asked them about the COVID vaccine, and people were very comfortable getting the COVID vaccine in community pharmacy, 73%. And actually our other polling work shows that people are very happy to have a growing number of services delivered from the community pharmacy. But as you might have noticed, this year's Asking Pharmacists campaign has had the tagline "Proud to be part of the NHS family," and that's building on those findings we had from that research. That's something we really need to emphasise when we're talking about the role of community pharmacy now and in the future. I can move on to the next slide, please. And, we have got really strong public support for community pharmacy at the moment. And back in September, we got two consecutive days front page stories from the Daily Mirror supporting community pharmacy. They put those pages there because they knew that their readers feel very strongly about community pharmacy and want it to survive and thrive. But I think it shows how we're valued, but also how we have had some successes in our advocacy work to be able to get these high-profile stories in tabloid newspapers. Move on to the next slide. I think we've got strong public support at the moment. We've got strong political support as well. So Matt Hancock said he's a massive fan of pharmacies, and he's using a phrase that we started using a few years ago: front door of the NHS. We think that's a strong way to present community pharmacy with a lot of our strengths. And it's great when the people you're trying to influence actually use the words that you came up with. We have a really good supporter with Matt Hancock. He's also said the budget is going up, and I want to do a deal with pharmacies where we offer more services to be delivered in pharmacies, and we pay people for that. And he also made the point that within the NHS budget, he wants to drive more money to community pharmacy. There is a battle going on in government at the moment over how community pharmacy is funded. Really, the Treasury doesn't want to pay out any more money, and they're trying to push this on to NHS England and tell them that they've got the money. Ultimately, it doesn't really matter to us where the money comes from, just that the financial settlement improves. And next slide, please. So my final slide, having showed what public support we currently have, what political support we currently have, is to talk about the reality of the funding, because we can't move forward unless we sort this out. So earlier in the year, we commissioned Ernst Young, now known as EY, to have an independent look at the funding of the sector, because clearly it's important to have an independent voice here, not just the sector saying it hasn't got enough money. So EY is a global consultancy and accountancy firm, found that about 1/3 of the network is in deficit, and this could increase to 85% by 2024. And they've calculated that there's a £497 million deficit in NHS funding, or there will be by 2024, just 3.5 years' time. They found that 87% of pharmacies report they can't afford to take on staff to provide extra services because of the funding situation as it is at the moment. And their conclusion was that NHS funding is insufficient, and that only the strongest, financially strongest, will survive, not necessarily those that delivering best service or in the areas where the service is needed. So, it doesn't even work for NHS England, the way that the funding is set up at the moment. So I think that's the background. We've got really strong public and political support, but we have a very difficult financial position, and somehow we've got to work out how to move forward in a way that harnesses that public support and comes up with a service and funding model that works for the sector long term. So back to you, Andrew.
Thank you, Gareth. I just noticed one question's come in from Neil Trannis. Thank you, Neil. Gareth says pharmacy has strong political support, as you did, but is it not disappointing that the government has so far failed to fund the profession sufficiently during this pandemic? So, Gareth, maybe you just want to answer Neil on that one.
Yeah, it is. The current situation is very disappointing, and ourselves and PSNC, and we've been working closely with PSNC in the last few months to lobby for a better outcome for community pharmacy. We need the funding to cover all the additional costs that were incurred or are still being incurred, and we need a fundamental improvement in the financial position. We've been lobbying very hard over the last few months. Disappointing we haven't got the outcome we want at the moment, but we're continuing working very hard with others in the sector to get us to the place that we need to be.
Thank you, Gareth. It's true to say, obviously, that we are continuing to lobby, of course, as well. We haven't just stopped from what you saw in the media. We had quite a sort of session with various ministers over the last sort of couple of weeks. So this is not something we're going to give up on lightly. There's another question that, it's gone. I think it said, would the slides be available? So I'm not too sure, Gareth. Will the slides from this session be available?
Yes, I'm sure we can make that happen at the end of the session. That's not a problem.
And Mahesh, a question from Mahesh. Are we going to make sure we use the PwC reports?
Do you mean the PwC or the EY report? I mean, we're continuing to use the EY report. It's still relatively new information, and we're still taking that round to stakeholders, ministers, civil servants at the moment, really trying to get them to understand the findings of the report. I don't know, but there have been two important PwC reports in the past, which we continue to use, in particular one that showed about 4 years ago, the PSNC Commission, that showed that just 12 community pharmacy services were more than covering the cost of the community pharmacy service. And actually, therefore, community pharmacy is returning. It's not a cost to the NHS, it's a value to the NHS because of the outcomes from just even a few of our services. So we certainly use all of those reports. Okay,
and Mahesh has just confirmed actually that it was the PwC report published a few years ago that he was effectively suggesting. And Andrew Boyle has suggested, is the EY report available to view somewhere, Gareth? Have we got that on our website currently, I think?
Yes, it is on the website. We can send a link at the end as well, but it's available on the website.
Great, lovely. Thank you very much. Okay, so let's move on. And obviously, because this session is all about, the longer term and where we're going, our next speaker, Rina Barai, who's an NPA board member, is going to talk about some of the clinical services opportunities that are perhaps open to pharmacies now and what we hope will be in the future. Rina, over to you.
Thank you, Andrew. I think I need to recognise before I even begin to talk about opportunities and new clinical services that actually I can sort of hear the frustration already in people's questions and comments, and when I meet members as well. We're being asked to do more, and how can we do any more for any less, basically, because we're already struggling. We've never been busier, have we, as community pharmacists, and also we've never been, so challenged in funding wise as well as we have in the recent few years. So I can understand how people are thinking, this is an interesting conversation we're having, an interesting title, enabling us to do more when we're struggling in the first place. But I do think we need to be optimistic, and I do think we need to think about clinical services opportunities. And I think there's two reasons why we need to think about that. One, because our patients want it. And I can just tell you a story this morning. I had one of my patients ring me up this morning who'd come a few weeks back for a blood pressure check because the GP had asked him to come here for a blood pressure check. He'd had his flu jab with us as well last week, and then he rang this morning saying, I've been to get my medicines from you. I had my blood pressure check. I've had my flu check. Can I get my PSA blood test from you as well? And that's, that's one of my patients, an 86-year-old man, just realising the benefit of community pharmacy and the services that could be offered by a community pharmacist. And the fact that he had all those other tests done with us and jabs and medication as well. Why not? Why can't he come here? And so I think our patients will really lead the way in those clinical services that we hopefully will, embark on in the future. And I'm sure many of you over the COVID pandemic have wished you could have written a prescription for a patient rather than having to refer them to a GP just to get a very simple prescription-only medication, for example, if you're an independent prescriber. Many times you wish you could say to your patient, you need a blood test. I wish you could just write one out for them and, get them to go and have a blood test. Or sometimes you may wish that you could have just changed a dose or a formulation or a strength of something without needing to refer to a prescriber. And all of those clinical opportunities are there for us, aren't they? They're there for us to sort of grab and to take and move forward. I also think the other reason why clinical service opportunities are going to be quite great for us is the fact that we're actually dealing with a lot of displacement activity. I know I am definitely, I'm sure you are as well, if you're listening, dealing with all of those patients coming into our pharmacies that would normally have gone to their GP for so many of the queries. We're dealing with a lot of queries from allied healthcare professionals, the dentists, podiatry, dietitians, all these people who aren't seeing patients as frequently as they were. But also secondary care from NHS, outpatients, where patients are not being seen face to face. And actually we're picking up a lot of that clinical activity. And we're doing that for free, aren't we, really, unfunded? And we're doing that because we're there and we're accessible and we'll do anything we can for our patients. But actually all of those scenarios are also allowing us to build that clinical service opportunity for our patients. And actually just thinking ahead to the next few months, you're hearing the mumblings of the COVID vaccine being available soon, and with possibly primary care very heavily focusing on making sure that the nation is providing that COVID vaccination to people. Where are people going to go if they can't go to their doctors for their appointments because they're too busy giving the COVID vaccine? So we're going to need to provide those extra clinical services over the coming months. And at the NPA, there's one thing that we're very sure about, that actually services will go hand in hand with supply. We know that actually we've got a very core essential service of supply and we don't want to get rid of that. But we also do believe that we have the workforce and we have the capacity and capability, actually probably more to offer these clinical services to our patients, and we know that our patients want them. But actually any of the new services that we may think about or may be able to sort of have conversations with the powers that be, with the powers that be, we need to make sure any clinical services that we sort of offer, we can do at scale. We can do quite easily without needing to jump through many hoops of education and training. We need to make sure we're providing that value for money for the NHS, and as Gareth said, the PricewaterhouseCoopers report a few years ago did say that actually many of the services that pharmacy provide more than cover themselves in cost in terms of the value that they provide for the NHS. But actually we need to learn from maybe some previous mistakes with services that we have offered in the past. I'm just thinking about medicine use reviews, they're now going, which is such a shame because at the time where we could probably do with, being able to continue to offer them. But maybe we should learn from some mistakes there. When we have these new services, we need to make sure they evolve. We need to make sure that we're providing and collating data on the usefulness of these for patients, and also feeding that back to the NHS, and just making sure that services don't stay stagnant, and we can, make sure that we evolve them to be to support patients better with different conditions, for example, and increasing the scope of these services. So I think what we'd like from as the NPA is to hear from our members as to some ideas for the possible future clinical services that you wish you could offer but you don't at the moment. And what we mean by these is NHS funded services, not private services. And I understand that people's frustrations at how we've not been able to access more funding during this COVID period. But actually there is some scope here to develop these services because there's a need by the NHS to have these services in place. So we'd really like you to get in touch with us and give us your ideas, and also thinking about whether these are national funded ideas or possibly even locally funded ideas, which we could work together with primary care networks, for example, locally to get local clinical services commissioned in a sort of primary care network footprint as well. So I'll leave it there, and if anyone's got any questions, I'll keep an eye on the Q&A as well.
Great, thanks very much, Rena. I don't see any immediate questions, but again, I think we're more than happy to take them as they come along, even if we summarise them at the end, possibly. So, right, well, there seems to be quite a lot of discussion about funding out there. And obviously, I think we, as the NPA, we've highlighted the need for an improved settlement for community pharmacy and to think about where we may need to go differently in the future. Now it's time to think about what we want from a future 5-year deal. Clearly, supply and service cannot be separated, as Rena just said, but there are other things that we could change about that model. So, I just want to spend a little bit of time maybe just going over some headlines, let you know where the NPA's thoughts are currently and how that might sort of progress. Clearly, community pharmacy funding has been getting tighter year on year since 2016, and obviously it stands now, we've got another 3.5 years of flat funding to deal with. The financial position is incredibly challenging for all of our members, and bearing in mind, we're all on the board, we're all experiencing that same financial challenge. An NPA commissioned independent report from EY proved what those of us in the sector already knew. There are serious underfunding issues from the NHS, that an extra £500 million is required by 2024 to meet the shortfall, as Gareth has just described earlier. So the NPA, instead of being quiet on this, you've seen us in the main press on TV. We've been lobbying for the COVID costs right from the get-go, and the long-standing funding gap to be filled. And that's something that we've had promised by the Secretary of State, and we will continue to press for the Secretary of State to be made good on those promises. But we also need to think about what we do for the long term. So if we going to work more closely with the NHS system, then we really need to think about, do we need to change? It's key for us that supply and service are delivered together, and that, again, echoed by Rena, but with a proviso that, are there changes to the way that we're funded now that would be helpful? And, do we need to start thinking about how that might be different going forward? And services alone don't provide sufficient income, as Rena, again, has just described. And it's already noted by EY that community pharmacy funding is not fully loaded, which is why services are paid at a much lower level than other health providers. And that needs addressing. So if we are to give certain services that other health providers already provide in the system, then it needs to be provided through pharmacy on an equitable funding basis. So that needs to change so that effectively when we deliver services, we're paid appropriately and fairly, which is what we're asking really. So should we have a funding system based on capitation payments rather than the volume of medicines dispensed? That's one for us to think about. We already know PSNC are thinking about other models. So that's something, again, perhaps that we should start thinking about at the NPA. Now is the time to think about this well ahead of any significant changes that may or may not be possible when the current 5-year arrangement ends in 2024. we don't want to get to 6 months before the next deal comes along and we haven't thought about what that next 5 years should look like for us and our members. We have to have a robust debate. We want to start that debate now and ask ourselves what's the right approach for our membership of independents and independent multiples, of course, because we don't just speak for the independent with one pharmacy, we also speak for independents with groups of pharmacies. And I think it's really important that everyone recognises that we have a diverse membership out there that clearly will be impacted in different ways, depending on what we all agree should be the way forward. So I think perhaps happy to take questions on the funding as it comes. If there aren't any immediate sort of questions on the funding, I want to pass across to our next speaker, Nick Kay, who is our pharmacist and board member and business owner from Cornwall. Also owns part of a GP practice, so very, very across everything that's happening in primary care currently and the system, of course. So Nick wants to talk about the system, which includes, how ICSs are being integrated, how PCNs are part of the system. So Nick, without further ado, I'll hand over to you.
Thanks, Andrew, and thanks everybody for giving up some time to join us today on this important topic. When I was asked to talk about the system, as Andrew says, it sounds quite scary, the system. It reminds me of those of you who are old enough to have watched The Matrix, men in grey suits, and how does the system actually work? And I think for us at the NPA and for all of us as pharmacists and people as part of that system, we need to engage with it, whatever it is. And if we look at it, we would be saying that, the NHS is obviously part of our primary system. As Gareth alluded to, people not recognising that community pharmacy was part of the NHS family, which is the system. But also the way in which people engage locally is going to fundamentally change and is fundamentally changing. So if you think about the things that Andrew's talked about, integrated care systems and also primary care networks, those localised systems are going to take a different way of engaging. And those systems create both benefit and potential risk to all of our operations. We've heard about the recruitment phase of primary care networks and community pharmacy and draining pharmacists and now pharmacy technicians potentially from community pharmacy. But I think what COVID has made us realise, given not only those funding challenges that Andrew's described so eloquently, and also the way in which Rena's described the opportunities that are out there, that the system is going to need us to do more. COVID means that GPs and general practice as part of the primary care system, which we are absolutely and fundamentally part of, are going to need our help. There's going to be more than enough work for absolutely everyone, whether that's the local system understanding the implementation of the national system in the GP CPCS service and how we can remove the on-the-day demand from our GP colleagues is going to be crucial. But also those long-term condition managements, it should be a space in which we could absolutely play. As Rena described, those of us that are independent prescribers, why could we not do some of that management? Now, I think the system does need some safety regards within it. It needs to understand what we do. It needs to understand our skill set. And we absolutely are the right place to champion those points of view, both nationally and locally, with deliverers of great national service and also local opportunity. So I think, again, if you look at the EY report and what Gareth described, we are going to have to engage in the system. It's whether that's national through the NHS and Public Health England, whether that's local through primary care networks and integrated care systems, and the multi-professionals that sit within that, not only pharmacists. The public are going to want us to do this, as Rena's 86-year-old man with his PSA test describes. The NHS are absolutely going to need us to do this, and we will have to step up to deliver this. And I think the reflection of a more complicated system is things where the NPA can absolutely help you engage with that, because this is going to be a job for all of us. So they were my reflections on the systems and how we should be more integrated into them, not given the fact that we should probably have more interoperable information technology as well, and communication being a big key of it. and that in Cornwall, I would say this acutely, that the workforce shows that the system needs to work together. Don't move us into general practice, allow us to do some of that work in our own settings within our own estates. Andrew, I'll hand back to you of my observations on the system. Happy to take any questions at any point. Thanks very much.
Thanks, Nick. I can't see any questions in the chat box at the moment, but I think one maybe that our members might want to learn from you is what should they be doing now locally? So, you know, if they haven't got engagement from their local system, what actually can they do to start being proactive, to drive relationships that they need to build that are going to be absolutely vital going forward? I mean, I can speak in Gloucestershire. We started the journey 2 years ago, you know, so, and we only really have just got to form PCNs with PCN leads. So it's taken an awful long time to get there. So what would you suggest, Nick, that our members start doing now?
Yeah, so thanks, Andrew. So in our national contract, obviously, we will have those pharmacists that are designated representatives from a community pharmacy point of view with primary care networks. Again, from a Cornwall point of view, I know of the 17 primary care networks we have in Cornwall. There's lots of community pharmacists hosting, for example, Zoom meetings. One was done in the primary care network that I'm in now, Falmouth and Penryn. One of the pharmacists, Ollie Williams, there actually hosted a meeting where he got all the local surgeries around all the community pharmacies to start the conversation. So if you look at where this would be an example of the systems working together, we're going to need local engagement to deliver properly the national service of the community pharmacy consultation service, GP referred. And those local leaders are going to be absolutely the people that will drive that. So what I'd be saying is, as a first step, identify who your primary care network lead is for community pharmacy. If you're making those PQS declarations, you should know who that is. And those people should then be in turn talking to the clinical directors. Or they're actually one of the most useful contacts we have are the strategic managers that are attached to the clinical directors, because those people tend to get systems and understand them more. So I would be, you know, your LPC could probably tell you who that is if you need to. But for me, it would be around engaging in those nominated people. That's why they're nominated, and starting those conversations locally. Again, we all do it, don't we? You know, when I've ever done, you know, back in the days when I used to do a locum, if I was in a health centre pharmacy, I'd always go in, introduce myself and go, hello, I'm the drug dealer from next door. I'm not sure that's an opening gambit that you can use, but it certainly gets people with a titter and, you know, chocolates I find help as well. So I think as well, all joking aside, the NPA and our members and those independent members, because we can hold great relationships. Our pharmacist staff turnover tends to be less. You know, relationships can be built more, trust builds more, and I think that will be really important in delivering the services of the future, Andrew. Thanks.
Thank you, Nick. Shailesh, good friend of mine, Shailesh Amin, just made a question on the chat. What are the measures should I be closely examine as a business so as not to hit the wall in 2024? So thanks for that, Shailesh. And maybe we're talking about the future here, you know, the clinical opportunities that are going to come that Rena's alluded to. Rena, is that something, do you want to take, what sort of things should we be doing in the business now so we're ready for the 2024 and what that might look like?
I think that's a really good question, Shailesh. It's something that's on all of our minds, I'm sure. We're all sort of sitting there every month thinking, am I making money? Is this worth it? Where am I going with this? Am I going down a road where this isn't a good place to be going down, or are there opportunities that I need to be seizing now? So I think all our members should be asking that question. And I think also with the EY report, I think what we're hoping to do is create some sort of system by which you could probably Gareth will probably explain this better than I will actually probably, but a way in which we can look at our businesses to see whether we are going in the right direction, especially with all the information that we found from the EY report. I might hand over to Gareth because he'll probably be able to explain it a lot better than I will.
Okay, Rena. Gareth, do you want to have a go at that?
Yeah, it's another output from the piece of work we've done with EY. So because they got hold of very detailed financial information about pharmacies as part of the survey that they conducted, they are building a financial model which will allow people to plug their own current numbers in. So you put your numbers in for this financial year, your income, your outgoings, and it will then project what your business will look like for the next 3 to 4 years, given what we know, given assumptions they've made about inflation and minimum wage and pension requirements, and all of these things factored into this model. And I think the great thing is you can then play with it. Once you've set it up, you can see, well, if I brought another member of staff in here and was able to increase service income here, what would that do to me, in 3 years' time? So I think it'd be a really useful tool, and we hope to have it available possibly by the end of this month.
Thanks, Gareth. There's a couple more questions actually come in while we've been having that chat. So one from Andrew Boyle. Community pharmacy is probably keen to offer more adequately funded clinical services through our pharmacies. However, we are still operating in the pre-COVID world with a dated IT system and consultation rooms. The NPA could help greatly with this transition in terms of both process and physical design. And I absolutely agree with that. And that goes to Shailesh's earlier point. And what should you be doing in your business now to get ready? So that's something the NPA are looking at how we support businesses in that specific way, Andrew. So thank you for that. Chai Patel has come out with one. In order to provide quality services, he said we need one to be there to be a payment to recognise the cost of running any parapharmacy. Not too sure what you meant by that, Chai, but I think I know what you mean. And two, services should be based on capitation. Interesting that you think that as well, possibly. Not on activity only. And three, there are a number of local services that are currently being provided that should be made into national services. Absolutely. We shouldn't have to fight to agree about commission services locally when it makes sense to have a national agreement on specific services that we all believe that add value to the patient. And if you look at the stats that Gareth put up on the recent survey that was done, was it 42% of people went to the GP during lockdown to talk about minor ailments? I mean, 30 million people went, I think 2/3 of the population went to see a GP, but actually, because they were closed, they came to us. Hence, Rena's point earlier. So there absolutely needs to be a suite of services that we get paid properly for to recognise the extra demand out there that we can save a mountain of time for the GP and the system. So I don't think I've got any more questions coming through on the chat. So can we go, if we don't mind, to the next speaker, Michael Lennox, who is also CEO of Somerset LPC. And Michael works for the NPA. Michael is going to provide some of the key thinking, the NPA thinking on the right review in about the next 5 minutes, if that's all right. And we'll take any questions after Michael's spoken. So, Michael, I know you've got a bit of a dodgy line down in Somerset. That's probably one of the penalties of living in a really, really nice area. But over to you, mate.
Thank you kindly. Firstly, can you hear me?
Can you hear me? Yes, we can hear you.
Okay, thank you. And I'll turn my ugly mug off video if it proves to be unstable, and we'll just go for voice. Look, firstly, thank you for making the time to join us. And as Andrew said, I support the NPA on all matters kind of local integration. So the whole idea about how local is made to happen is absolutely my key area of policy and practice to support the NPA. And I kind of wanted to kind of kick off by not going through the last year of the right review, because believe it or not, folks, we've been looking at this for damn near 12 months now. And I think looking backwards will probably not be of real merit. Let's find out where we are now, and let's have a think about how we can move forward. I personally believe that actually Nick, my colleague Nick, was spot on right when he was talking about building those local relationships. What the review into representation and support called for way back a year ago was better quality optimized representation and better quality optimized support, both from the PSNC and from the LPC network. And both bits have to work in tandem to be able to deliver that. So what's happened? Well, we had 6 months of Professor Wright and his team creating a review report, and the research they did was massively compelling. They landed a bunch of recommendations, then 33 recommendations on the table. And that then caused our entire sector to go into a period of reflection. And since those recommendations and research landed with us back in May, we're now entered November. And I think it's fair to say that it's been really difficult to create a sense of consensus around the recommendations that Wright put on the table. So where are we now? We're kind of moving ahead into a next phase. And with respect, it's no longer being called the Wright Review, it's just being called the review. Now, I suppose the spirit of Wright and some of the things that Wright found will actually be carried forward. But where we are at the minute is on the cusp of forming the mechanic by which it will go forward into that phase 2. And that's a review steering group, or RSG to its friends. Now, that RSG is being constituted almost as we speak. And I'm not going to recap the rather excellent PSNC webinar from last Wednesday night. If you haven't seen it, look at it, or at least get the slides and flick through them. This is important stuff, because if we as a sector don't get together and create a right outcome next, then the review itself is not going to deliver for contractors. And David Wright found that contractors wanted change. We have an obligation to deliver on that change. So we've now got another 4-month period or so to take us to kind of March. And out of that, this RSG is going to convene. Now, we within the NPA are supporting the independent side of that RSG convening. And we're looking to support our dear colleagues who are likely to end up on that. So four talented, committed human beings from the independent sector are going to sit on the RSG, and they're going to make the strong independent voice be heard within the RSG itself. But they're also going to collaborate and work with their other colleagues, whether they're from AIM, PSNC, or indeed CCA, to find us a mutual path ahead. Because if we can't find a collaborative, collective, way ahead on this, I sense we will have failed ourselves. There's no way at the minute that either the PSNC or the LPC network are optimized. There must be a way by which we can work together to find an even better way of representing and supporting all contractors, no matter which bit of the sector they're in. To that end, the NPA came up with a set of pretty clear principles that we haven't deviated from, folks. If I could have slide 2, please, that would be splendid. And these 8 principles have not changed. I mean, we in the NPA believe that getting national right is absolutely critical, but almost always national comes from local. And if you don't increase the capacity for local service development, you probably won't end up with those magic moments of new services. And everything that's been invented really in our contract, somebody in a local health economy invented, did it, piloted it, and then shared it. Secondly, there's a network of 69 LPCs at the minute. Some of them are massive, covering 300, 400, 500, 600 contractors, and some of them are tiny, covering 30, 40, 50, 60 contractors. Is that right? Is it right to have 69 separate organizations with that degree of variance? Wright thought not. And actually, a lot of other people think that you need to cut your cloth to be the right size to be in the local health economy. But from 30 to 300 or from 60 to 600, that seems a very big range, doesn't it? Thirdly, the PSNC needs to do its core function. Its name is the Pharmaceutical Services Negotiating Committee. So its mandate must be very clearly to have the right kit in place to be able to negotiate a really effective deal for contractors. Fourthly, we need to invest in local leadership, not divest from it. 1,259 PCNs are now out there, and damn near there's a PCN community pharmacy lead for each one. Who's working to help them be effective micro leaders? LPCs are, but what else do we need to do? Fifthly, I guess improving transparency and accountability in relation to expenditure. That one came through. And these organizations are funded by our contractors. You as contractors, you put your hands in your pocket and you put the money on the table. Are you getting the best deal? Do you know what sort of a deal you're getting even? So upping and dialing up governance and transparency is critical. We also believe that kind of piloting any changes that we come up with would be a sensible way forward. And then lastly, do you know what, there probably needs to be a different way of working where regions become more important. And we're seeing that at the minute with the 7 NHS England regions and how LPCs are beginning to coalesce at a regional level to more positively influence what happens locally. So a little bit around the principles themselves. We're not deviating from those. Those absolutely remain. The other thing that's really important here is a strong NPA, and a strong NPA that does the right thing collaboratively with the other leadership organisations in community pharmacy, but also actively reaches out and enables what LPCs do to support contractors. So we will be doing a bucket load more stuff to support the 69 existing LPCs to more effectively support the 3,000 plus independent contractors across their patches going forward. That's a solemn pledge. So I think that's enough for me, Andrew, and hopefully my broadband more or less held up.
Yeah, it did pretty well, actually. That means you probably have to switch it off for the rest of the afternoon now.
Not sure it works like that, Andrew, but I'll give it a go.
Yeah.
Any questions?
Let's see. I've got a couple. One probably is a funding one. I'm just reading another one from Shailesh again. I'm sorry to harp on, but I need to start charging for the fee service care, such as MDS preparation and delivery to patients, along with cutting my staffing costs in order to survive. I also need to keep a close eye on monthly management reports to be ready to arrest any bleeding of cash. I would like the NPA to come up with a robust business plan to cost stabilise my business and financially before we look at and search for clinical opportunities. I say this because otherwise it will be too late. So does anyone of our panelists want to take that up? I mean, Shailesh has got a good point here. It's all right having a future, but if we can't actually shore the business up now and make it financially robust, there is no platform to build anything on. Now, that perhaps wasn't a question for you, Michael. I know you've just provided your presentation, but maybe does anyone want to sort of answer that? Maybe
can I mention something, Andrew? Because not artificially shoehorning that question into my bit, but I think our colleague there is spot on, right? In fairness to the PSNC, they've been banging a drum really loudly on this one. In fact, this summer, we did an audit to find out what sort of free stuff interventions we were doing, and that is really potent. So I think your voice has been heard right at the top in the PSNC. Plus, I know that LPCs are representing that position very, very strongly on the ground. Our contractors, our members will not do stuff for nothing when it's jeopardizing their own businesses. So I think representation and support, both at national and local level, is being dialed up on that very issue. But it is interesting, the point about the NPA, Andrew, and whether or not we can issue any further support or guidance on that. So I'll pass back to the panel for that.
Yeah, no, sure. Absolutely, Michael. Thank you. Rena, did you want to pick any of that up at all?
Just to say, I agree with you, Shailesh. This is exactly what we're all worried about. How do we start doing new things with the security, going forward, that we will hopefully have the funding to be able to do all these new service opportunities, because they will all take time, investment, staff, training, etc. So I do understand his frustrations. I think the idea of a business plan is a good one. It's definitely something we could think about at the NPA. I think the EY tool that Gareth mentioned earlier will definitely help us to support, contractors to know where your business is. But the problem we have, I guess, is we've all got different business models as well, which makes this, creating a business plan quite complicated for community pharmacy. Even within the independent sector, we've all got different business models. But I think I just want Shailesh to be reassured that we're very alive to all these concerns and very aware that these are the issues that all of us are facing. And definitely something like a business plan is something we will look into.
Thanks, Rena. And Chai Patel has said, in the current contract, we've lost the establishment payment, and part of that payment was used to pay us for the free advice that we provide our patients every day. But during COVID, of course, especially this advice element has gone through the roof, as we learned from the statistics that Gareth provided earlier. But no payment for this extremely valuable service has come through. Please, can we address this? Absolutely yes, Chai. I think that's part of the job of PSNC, but equally we are here to lobby and make sure on behalf of our members that we want to make sure that we have a properly remunerated system, but we need to look at the future, what that looks like. So does any of the other panel members want to maybe come in and Nick, have you got a view on that perhaps?
Yeah, so I think there's a couple of things actually, because I think those two questions are kind of interlinked, both Shailesh's question and the question you just read. I think because for me, what I'm taking from this now is hand on heart, honest, safe space amongst friends. I can't be this slow to operationalise things like GPCP CS as I was for MURs and NMS. I just can't within my own business. So there has to be ways of that the NPA can also not only, as Rena says, creating individual business plans is very difficult because lots of people have different rents, running costs, all those other things. But I think champions of how you connect and deliver best practice to operationalise all the opportunities that currently exist, which, I didn't operationalise properly. It took probably a good tranche of cuts for me to go, actually, there is no fat in the system. I cannot do this. I have to work in a different way. And for us as the NPA, how we maximise the opportunities that are currently available to us, both, commercially through how we deliver those services, but also, how, for example, the free advice. We want to be accessible. We want to be part of it. That's part of our strength. However, how do I operationalise those commercial opportunities and service opportunities? Because ultimately, that's better for the patient. It's better for us because we're more robust. And again, we start to integrate, to bring back to my topic, into the NHS system. If we're doing 500,000, or 1 million consultations, every month in community pharmacy, then, it's a powerful thing to suddenly turn off. The system won't like that very much. So for me, the NPA places, a support for PSNC to address the funding, but also around how we share great stories, great practice, and how we deliver those opportunities that are there, Andrew. Thank you.
Thanks a lot, Nick. So there's plenty of food for thought there. In the last 5 minutes, we don't appear to have any further questions. I just want to make an observation. I've been talking to the public this last week and a lot of press as well. And what was really evident, obviously, in Ask Your Pharmacist Week last week, when we started to make, conversations with radio presenters and people like that, how many of them were unaware that pharmacy did the flu jab, for example. It really was surprising that even those radio presenters who were out there as members of the public were totally unaware that pharmacy did the flu jab. When I started talking about flu as if it was a lead-in to us doing the COVID vaccination, but they weren't even aware we did the flu. So I think there's an awful lot, and maybe the NPA have a role in this. I don't know what anybody else thinks on the panel, but maybe we are just not good at marketing what we do. Rena?
Just an example I was going to share. So as Ask Your Pharmacist Week last week, the NPA offered for members to have some leaflets printed, which I did. So I had them printed, I had them delivered on Saturday by a local company. This morning I had a phone call from one of my customers who's used my pharmacy for at least 10 years, saying, I had a leaflet through the door, Rena, for your pharmacy. I didn't realise you did flu jabs. And he's been coming to my pharmacy month in, month out. I'm sure we must have asked him, maybe we've just missed him. But he didn't realise he could have his flu jab at my pharmacy, yet he's been coming to my pharmacy for all these years. So I think there is, we've talked about lots of opportunities out there and lots of worries and concerns. But actually, sometimes we need to go back to basics, as you say, and just try to sell ourselves more, be that to our own patients, be that to our local PCN, primary care networks, be that to the wider NHS. We are a great sector for the NHS. We pick up all the pieces of all the work that's going on everywhere, and we just don't do enough to shout about it and to make sure that we're really making ourselves known. So just wanted to share that reflection.
No, that's a great reflection. But on the basis that we're doing all these potential extra services, we need to make sure the remuneration model fits that. And I think one thing the NPA will be doing and talking to its members over the next coming months with what sort of alternative remuneration structures are out there to allow us to do this. So, it's really great to start this debate. We're more than happy to have, all of our members feed into this debate on how we should be remunerated going forward. Because as we said earlier, we do not want to hit the next 5-year deal without a plan. We've got 3.5 years to come up with that. We're engaging with our members on what our members think that alternative future should look like. We're also in clearly strong discussions at the moment with local systems, as Nick has described. I can testify in Gloucestershire that my local CCG is very, very keen to have us engaged in COVID vaccination. We've had a big programme this year on flu that's ramped up massively. And I think, that old adage, you do business with people you know, to Mike Lennox's point out there, you need to get to, you know who your LPC members are, for example, who's batting your corner, who is your lead at the LPC on the PCN. So, who are your clinical directors on PCNs? You need to start getting out there, I think, and that's one message that's coming loud and strong from not just pharmacy, but I think from the NHS system as well. So before we close off, is there anyone else that has any questions? If not, maybe anything. Oh, I've got Andrew Boyle. There seems to be a lack of publicity across the board. GPs have already sorted COVID vaccination services. What's ours? So maybe, Nick, is that something you want to pick up, that question?
The question around the publicity. Publicity around...
GPs have already sorted COVID, Andrew's saying.
What I would say is, don't believe everything you read. I think there's an ambition for it to be done through general practice, but also it's a rapidly moving feast. I absolutely think community pharmacy can and will play in this space. I would, some of my reflection with my other hats on is that GPs aren't as prepared as you would think. Gareth, you've got your hand up.
Oh, and just to add, really, Simon Stevens, Chief Executive of NHS England, hasn't necessarily always been our biggest fan, but when he's been talking about the COVID vaccine in recent days, he has mentioned community pharmacy as one of the routes to get that vaccine.
No, that's a very good point, Gareth. Very good point. He did come out last week on BBC News and say exactly that. He said high street pharmacies will be getting engaged in the COVID vaccination programme. And I think we already know that some of our local systems are talking to us about wanting to be involved in that. So I think, Andrew Boyle, we can actually hand on heart say, yes, community pharmacy will be involved in the vaccination programme for COVID. And obviously, I'm sure PSNC will be negotiating what that looks like in terms of cost and price for us to achieve that. So if there aren't any further questions, I just want to thank our panellists. We've had a lively debate, I think. I'm sure this is the first of many this week. So, Michael, look, it looks like your internet is still working down in Somerset. So, hey, it hasn't passed 1 o'clock. No, it has. It's past 1 o'clock and it's still working. You're all right.
The NPA is a lucky charm.
Absolutely. So the other thing I've got to do, we've got an evening session tonight at 7:30. So Jasmine Shah will be looking at hot topics in pharmacy practice. So please dial into that on Zoom. I think you've had the links on the programme. So again, just thank everyone for attending. And Gareth, you've got your hand up briefly. Have I missed something?
Yes, just because we were talking about future direction, and there's a lot of thinking going on in the NPA about that. If anyone does have anything they want to contribute to our discussions and our thinking, or want to be part of any policy groups, if you get in touch with us through independencevoice@npa.co.uk, we'll then respond to you and involve you in whatever way you want to be involved in these discussions.
Great, fantastic. Even in internet works north of the border as well. I've got Martin Bennett up there in Yorkshire, so at least we managed to get the internet working in Yorkshire, Martin, today. So again, thank you all for all the attendees on this conference. So keep on dialing in. Again, thanks very much, and we'll join you later on with Jasmine's session. Take care all.